Dr Cedric here, and it's time for our Thursday CME again. So today we'll be discussing on a topic that's interesting yet not widely discussed, that is Cyclops lesion. So what is Cyclops lesion? It is known as the anterior arthrofibrosis of the knee, and it is a fibrous nodule of granulation tissue located anteriorly along the graft after an ACL reconstruction. So meaning to say it is a post-surgical complication that arises and leads to limited range of motion for knee extension. Another point we need to focus on here, take note, is Cyclops syndrome. Cyclops syndrome is none other than the Cyclops lesion that causes loss of terminal knee extension. And normally, patient will claim that there is a audible or palpable clunk on terminal knee extension. Okay, so now how do we further classify Cyclops lesion? So it is further classified into three categories. The first one based on the location on the ACL. The next one is based on the pathology. And the third one is based on presentation. So based on location on ACL, further divided into three. We have the classic, which happens at the tibia. We have the atypical at the mid-substance portion of the ACL. And then we have the inverted Cyclops, which happens at the femoral insertion site of the ACL. And based on pathology, we divide also into three. We have the Cyclops, we have the Cyclopoid, and we have the pseudocyclops. And for presentation-wise, it's divided into asymptomatic, which is known as a Cyclops lesion, and for symptomatic, it is called as the Cyclops syndrome. So for pathophysiology, Cyclops lesion is a pedunculated or non-pedunculated nodule of the fibrovascular tissue. And the arthroscopic appearance with its overlying blood vessel give the appearance of the Cyclops. And what can be the cause behind it? Up till today, the exact etiology is uncertain, but it is believed that microtrauma following injury can lead to this. And Cyclops lesion is also related to gradual fraying and bunching up of the remnant ACL or graft fibers, excessive fibrosis, or alternatively due to uplifting of the fibrocartilaginous tissue during drilling of tibia for the ACL recon, which serves as a nidus for the fibrous tissue deposition. Other than that, impinging of the graft in the knee extension is also postulated in regards with the etiology for Cyclops lesion. So the end result of this regarding the pathophysiology, regardless of the cause, is a rounded fibrous nodule sitting in the anterior intercondylar notch. And now we move to the risk factors. What are the risk factors? Kambapati et al. They reported there are 8 risk factors for Cyclops lesion. The first being the female sex due to narrow intercondylar notch. Second being the increased volume of graft in relation to the notch size. Thirdly, bony avulsion of ACL from the tibia and bony avulsion of ACL from femur. Next, anterior placement of tibial tunnel. Okay. Next, double bundle ACL recon due to higher volume of graft. And number 7, bicruciate retaining arthroplasty because of ACL injury or sharp tibial bone island. And 8, hamstring contracture. It is stated also in Pinto et al. That they identify a higher incidence of hamstring contracture-related extension deficit in patients with Cyclops lesion. Hence, from sports medicine point of view, it's very important for us to target on knee extension during the prehabilitative phase and also the post-op phase. What are the clinical presentations of Cyclops lesion? Cyclops lesion, normally only symptomatic Cyclops lesion will have symptoms, and they are known as the Cyclops syndrome. So they normally demonstrate loss of terminal knee extension, and the complaints of discomfort when they are walking, running, lying supine, and have audible or palpable clunks during terminal knee extension. Other clinical symptoms that we must take note is that they will have crepitus, painful cracking, stiffness, residual laxity, joint line pain and tenderness, locking of the knee, discomfort when climbing stairs. And for examination-wise, a special test that we can do is a bounce home test, where there will be a rubbery end feel. And it is called as a bounce home test positive when we try to terminally extend the knee. For sports medicine point of view, it is important for us to be able to diagnose Cyclops lesion if there is any, because urgent referral need to be made to orthopedic if, let's say, there is a diagnosis of Cyclops lesion made. And how do we diagnose? Normally is through MRI. MRI have reported about 25 to 70 47% of Cyclops lesion with sensitivity of 85% and specificity of 84.6%. So what do we look for on MRI finding? We will find a soft tissue mass seen anteriorly or anterolaterally in the intercondylar notch near the tibial insertion, or as I mentioned, based on the classification. How do we treat? Symptomatic Cyclops lesion, we refer also for arthroscopic surgical excision or debridement of the lesion. Prognosis is normally good, and our patient is able to recover to full function normally after arthroscopic debridement. For asymptomatic, we reinforce on physical therapy, and it is important to work on the knee extension post-operatively after ACL recon. So what are the exercises that we can introduce to the patient post-op? We can do prone hangs, supine low load stretch, calf and hamstring stretch with pressure, and standing loaded knee extension. So before I end, let us again differentiate between Cyclops lesion and Cyclops syndrome. So to differentiate them, Cyclops lesion, by definition, it is anterior knee arthrofibrosis. Cyclops syndrome, it is a Cyclops lesion that causes loss of terminal knee extension. Cyclops lesion diagnosed on MRI, where Cyclops syndrome is diagnosed clinically. Cyclops lesion is usually managed conservatively unless it is symptomatic, and Cyclops syndrome, we manage with arthroscopic debridement. That's all from me on Cyclops lesion. Thank you.